Loka samasta sukhino bhavantu. An ancient Indian prayer. In all of creation, may joy happen. Let there be tranquility. I am Dr. Yeldandi, a specialist in infectious diseases. This presentation is a brief review of the role of cytokines in the pathogenesis of injury to tissues. Many years ago, Lewis Thomas wrote, "Our arsenals for fighting off bacteria are so powerful and involve so many different mechanisms that we are more in danger from them than from the invaders. We live in the midst of explosive devices. We are mined." This was in his article, Germs, published in New England Journal of Medicine in 1972. Now, the immune system responds to undesirable entities by both pro-inflammatory responses and anti-inflammatory immunosuppressive responses. These events can be initiated by invading pathogens such as viruses, bacteria, fungi, parasites, but also by endogenous entities that are recognized as undesirable by the body. These are initiated by interactions between pathogen-associated molecular patterns and pathogen recognition receptors in the host cells at the cell surface. These are receptors like the toll-like receptors, the C-type lectin receptors in the endosome or in the cytoplasm, retinoic acid inducible gene 1-like receptors, and nucleotide binding oligomerization domain-like receptors. The consequences of exaggerated inflammation is collateral tissue damage and necrosis, resulting in the release of damage-associated molecular patterns that perpetuate the inflammation. Denning and Van der Poel show in this cartoon a very close association with damage-associated molecular patterns and neutrophil extracellular traps, which are basically a combination of neutrophil-derived histones and myeloperoxidases and other enzymes, along with DNA, that lead to further inflammatory changes. This is a key element that we see often in acute lung injury. As we see in this diagram by Channapanavar, a key host response to the coronaviruses is very similar to other viruses or pathogens in that the early interferon response is the key to pathogen elimination and limiting tissue damage due to excessive inflammation. Zhang and associates created a very elegant animal model, a transgenic mouse with human DPP4 expression, and they can show here that there is clear evidence of complement activation and deposition of the terminal complement membrane attack components in the lung tissue in MERS infection. And this suggests a very important role for coronavirus infections in complement-mediated acute lung injury. In the same animal model, they show that blocking C5, which is the common path for complement activation, attenuates the cytokine response and limits deposition of the membrane attack complex in lung tissue. Now, very interestingly in this model, blocking complement also dramatically reduced viral density in the lungs. Now, coming to humans, some of the early experience with COVID-19 infections as reported out of Wuhan by Professor Dai, Shi Tian and associates, what we see is that there is a marked lymphopenia. In fact, in the sickest patient, it goes below 800. This is something that is very notable, and we will come to this once again. In the same report, we also see that there is a marked depletion of natural killer cells as well as a marked depletion of T helper cells. Once again, in the very sickest patients, we see that ferritin starts going up. In fact, The cutoff number here appears to be 800, which is again very interesting, and we will come back to this phenomenon again. And in this very interesting paper by Pedersen and Ya-Chi Ho, we see that in severe COVID-19 cases, there is an increased production of IL-6, IL-2, IL-10, and TNF-alpha, while total lymphocytes, once again, particularly CD4 T cells and CD8 T cells and interferon gamma expressing CD4 T cells are markedly decreased. The level of the cytokine storm and T cell lymphopenia is associated with pulmonary damage, respiratory distress, and an unfavorable outcome. In yet another report from the early experience with COVID-19 infections, Chen and associates report a marked increase in the pro-inflammatory cytokines, in particular IL-6. And in some early data from autopsy reports of COVID-19 infections, Bo Diao and associates saw that just as in the animal model of MERS, in humans also with COVID-19 infection, we see deposition of the terminal attack complex of complement in kidney tissues, once again confirming the role of complement in acute kidney injury, in addition to possibly direct involvement of the virus also in the kidney. So what we are seeing in the sickest patients with COVID-19 infection is that there is a marked increase in pro-inflammatory cytokines, marked acute lung injury, acute kidney injury, and marked elevation of the ferritin, all of which are very reminiscent of the macrophage activation syndrome that we have seen in other viral infections such as EBV, CMV, influenza, the Crimean Congo hemorrhagic fever, histoplasmosis, and other syndromes that are part of the hemophago-lymphohistiocytic syndromes. So in summary, the cytokine storm that we are seeing in the sickest COVID-19 infections suggests a role for blocking IL-1 with anakinra or canakinumab, blocking IL-6 with tocilizumab, blocking the JAK system with tafasitamab, and possibly blocking the complement system using eculizumab. The therapeutic implications of understanding the role of cytokines is that indiscriminate blockade of cytokines may be counterproductive. In fact, in animal models and previous human studies, we have seen that unless a cytokine is carefully selected and properly timed, it actually increases the mortality. Clearly, an early interferon response and inflammatory cytokines are part of the host attempt to resist infection. On the other hand, delayed interferon response may lead to greater replication of the invading pathogen, and lack of early clearance of the pathogen is in part responsible for the deleterious cytokine storm and the consequent tissue damage. Unfortunately, too early a blockade of cytokines may also predispose to infection. We have seen that clearly in treating rheumatologic disorders with antibodies directed against TNF-alpha, antibodies directed against IL-1 and IL-6, because chronic usage of all of these agents leads to increased risk of opportunistic infections. Therefore, what is key is timely interventions with blockade of IL-1, IL-6, and possibly the complement system. It's also possible that we may need to block it at multiple different loci rather than only one locus. Proper selection of the individuals who might benefit is absolutely the key. Now, the predictors of this macrophage activation syndrome, cytokine storm, in viral infections like COVID-19 is possibly an absolute lymphocyte count less than 800 and a ferritin greater than 800. This I am beginning to call the Yeldandi rule. So, to select patients, the Yeldandi rule, along with one of the following: fever, respiratory rate of greater than 20, hypotension, evidence of organ dysfunction, should be used to select individuals for using biologics to block the cytokines in addition to standard treatment. Now, it's possible that in the future, we may use genome-wide association studies to select out specific genetic markers that help us identify those individuals who are at particularly high risk for cytokine storm and therefore good candidates for blockade with specific agents. Now, clearly, in all of this, a controlled clinical trial is absolutely imperative. So thank you very much. I have put a copy of this entire presentation on our Facebook site, Happen for One Health. You're welcome to go and look at it. And once again, thank you for your attention.